Hi, this is Derek Erstad with Surgery Snapshots. I am a surgical oncologist at Baylor College of Medicine, and in this short video, we'll be talking about the open abdominal entry technique using a Pfannenstiel incision for colorectal procedures. There are three main purposes to this video. The first will be to discuss the rationale for using a Pfannenstiel versus other incision types for open entry. The second will be to discuss positioning considerations for the Pfannenstiel in both the medial to lateral and superior to inferior planes. And then finally, I'll talk about sizing of the incision. Thanks for watching, and I hope you find this helpful. There are three general approaches for any MIS operation for which you can get into the abdomen. One is the open technique, second is OptiView, and a third is through a varus needle. Now we're going to focus first on the open technique here. For a left-sided operation, whether it's a sigmoid, a left colon, or a low anterior resection, I generally prefer actually the Pfannenstiel incision. The reason I prefer this over, let's say, a periumbilical Hassan entry is because the periumbilical port site has limited utility for the remainder of the operation. The hernia rate generally tends to be higher. Pfannenstiel is more cosmetically pleasing. It can be a larger incision, so you can place a gel point and have multiple ports go into it, and the hernia rate is lower. Now for the placement of it, it's generally going to be a lateral incision anywhere from 5 to 10 centimeters in length, and it's going to be located at some position between the pubic symphysis and the umbilicus. We'll talk in subsequent slides about the specific placement of it. It provides an excellent field of view for subsequent port placement for your operation, particularly with the robot. As you can see on the diagram, with a robotic left-sided colon operation, generally your ports are going to be either in a lateral line just above the umbilicus, as shown with the dotted red line, or it's going to be in a diagonal line working towards the left upper quadrant, as shown with the dotted yellow line. In addition, you will typically place an assist port, which will be in the right upper quadrant, as shown with the red circle there. And you want to triangulate that port between your robotic ports so that the assistant has easy access to the operative field, which I've shown here on the diagram. So the Pfannenstiel entry is excellent because when you place the camera through there for subsequent port placement, it really shows you all the anatomic landmarks for triangulation. The other reason I really like it is, as shown in this picture here, you can place a gel point. This is a medium-sized gel point, and through that gel point, you have the freedom to place several different types of ports. I like to place a 12 millimeter air seal port through there because I think there's certain advantages of it. One is that your air seal is dealt with for insufflation. Secondly, if your bedside assist port is only a 5 millimeter, it's difficult to pass needles, Ratex, and other things through that small port, but you can do that through the 12 millimeter air seal port. So I think it's an excellent setup for assisting the surgeon. Let's dive deeper now into considerations regarding the size and positioning of the Pfannenstiel incision on the patient. The first consideration is the north and south plane. Options are a classic approach, which is typically 2 to 3 finger breadths above the superior border of the pubic symphysis, or a second option is what I typically use in my own practice, which is approximately 1/2 the distance between the umbilicus to the pubic symphysis. Frequently, the main consideration between these incisions is the size of the bladder and the risk of injury upon entry. I want to give you an example of this. On screen left is a sagittal view CT scan of a patient. It's a male in their 60s with BPH, and I want to point out some important anatomy. So I've shown here in the purple squares the umbilicus as well as the pubic symphysis, and shown in yellow here is the bladder. You can see that the dome of the bladder extends quite cephalad on this patient. Now, in the operating room, you're going to be navigating the distance between these two landmarks. And if you take the classic approach, which is 2 to 3 finger breadths above the pubic symphysis, which is shown by the red arrow, it's very likely that you will have difficulty navigating the bladder and will be at high risk for injury. Conversely, if you go approximately halfway between, as shown by the green arrow, it's more likely that you will safely enter the peritoneal cavity. Now, in your own practice, there are several things you can do for preoperative planning to help you navigate this. The most obvious one, which I've shown here, is to look at a CT scan. The sagittal view shows the anatomy best, and you can map things out that way. However, you should look at the patient chart for any evidence of BPH or medications related, such as Flomax or doxazocin. And in the OR, there can oftentimes be clues if it's been undiagnosed BPH. For example, if you have difficult Foley placement, or if the initial amount of urine after Foley placement is quite high, those may indicate bladder retention and an enlarged bladder. In the case of this CT scan shown here, this patient had over 1 liter of urine output after their Foley was placed. Now, enlarged atonic bladders are more common in elderly men because of prostate issues. However, they can be present in women and should be kept in mind. Having said all of that, let's focus in on the 2-finger breaths approach. If it makes sense in your patient, I do think that there are some advantages to that. The first is that it's more cosmetically pleasing because it's hidden from the belt line or the bikini line in most patients. In many ways, it's similar to placement of the suprapubic port in young patients for laparoscopic appendectomy. However, most patients who undergo LAR are generally not young, and cosmesis is not as high a priority. The second potential advantage is that sometimes a surgeon may want to use a contour stapler through the Pfannenstiel incision in an extracorporeal fashion. I don't do this in my own practice, but the lower you make your Pfannenstiel incision, the better view into the pelvis and ease with stapling you will have on the rectum. Now, the disadvantage is obviously the risk for bladder injury, but secondly, the more caudal that you go, oftentimes the thicker the subcutaneous tissue and abdominal wall will be. This is particularly true for patients who have obesity and a large pannus. And so in these cases, your Pfannenstiel incision may be at higher risk for wound breakdown and infection. Now, let's look at some of the considerations for placing it higher, half the distance between the umbilicus and the pubic symphysis. The advantages here are, of course, lower risk for bladder injury. The disadvantage would be that it's less cosmetically pleasing and not as reliable a port of entry for extracorporeal stapling. But because of the lower risk of injury to the bladder, especially in men, I think that far outweighs these other considerations. All right, now let's pivot and consider the lateral dimension of the incision. Typically, Pfannenstiel incisions are going to be made with a distance of either 5 to 7 centimeters, usually with a gel point mini placed into it, or it'll be approximately 10 centimeters with a medium-sized gel point. I think that the smaller 5 to 7 centimeter incision works fine for most cases. The soft tissue and fascia can be undermined underneath the skin to make the opening bigger for specimen extraction. However, if you are going to use a gel point mini, you do want to keep the incision small so that you're not leaking air throughout the case. This is particularly true if you're using an air seal, where you can have significant volume lost if your incision is too large for the gel point mini. Conversely, if you're going to use a medium-sized gel point, a 10 centimeter incision is fine. You will not lose a significant amount of air. I typically use the larger incision and the larger gel point for patients who are quite obese, or if they have bulky tumors, because I think the larger incision will make it easier to navigate these difficulties. In my own experience, I do not think that there's a significant cosmetic difference between the 5 to 7 centimeter incision versus the 10 centimeter incision. And so if there's any reason I think it might be easier with a larger incision, then I will just go ahead and make that